All right, good afternoon, everyone, and welcome to Support Hospital Opioid Use Disorder Treatment Shout Texas Echo. Please note that we are recording these sessions for later distribution. Note that your names do not appear on the recording of the session, nor does anything listed in the chat. Thank you all for joining us today. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick announcements before we begin. To help with the attendance, please enter your name, affiliation, and email in the chat function. We appreciate your support in helping us fully capture this record. We love to see everyone's smiling faces, so if you're comfortable and able, we encourage you to join by video, especially for the discussion portion of our session. We invite everyone to speak, but ask that you stay muted unless you're speaking. To mute and unmute, select the microphone icon on the bottom left of your screen. If you've joined on a computer, or if you've joined by phone, use *6. You can also communicate with the chat feature to raise questions and share comments. Please note that no protected health information is allowed in either the chat or our discussions. During and after the session, the Shout Texas Echo team will send out a link to an evaluation of the session. All participants filling out the survey will be automatically entered into a $30 raffle for a $30 Walmart gift card. So please go ahead and participate. Our didactic today is on effective and appropriate charting for patients with SUD. Following that, we will discuss a case presented by Dr. Michelle Katona. We will start with introductions, followed by didactics, announcements, case presentation, and open discussion. Thank you again for joining us at today's Echo. In the spirit of all teach, all learn, we encourage you all to share your experiences, questions, and insights in today's conversation. So we'll do some introductions right now. Dr. Walker.
Hi, I'm Blair Walker. I am one of the Shout Texas and DelMed kind of hub experts. I'm with psychiatry. Nice to see you all.
Thank you so much for joining us. Dr. Moriatis.
Hey everyone, Chris Moriarty's hospitalist and Shout Texas here at DelMed.
Thank you. Dr. Weems.
John Weems, I'm addiction medicine, primary care doc here at Community Care, FQHCs in Travis County and part of the Shout Squad at Dell. I'm also going to say Dr. Blair Walker is now a board certified addiction medicine doc. Shout out, major shout out.
Congratulations.
Thank you.
And Dr. Katona.
Hi, everyone. I'm Mitch Katona. I'm one of the emergency medicine residents at DelMed.
Thank you for joining us. Dr. Lindsay.
Hello, Adrienne Lindsay, Director of the Center for Substance Use Training and Telementoring at Be Well, Texas. Thanks.
Thank you for joining us. Alana.
Hi, everyone. Good afternoon. I'm Alana Bolton. I am the Program Manager of Shout Texas at DelMed.
Thank you. Andrea.
Hello, my name is Andrea Hebler, and I'm a program coordinator for ECHOS here at UT San Antonio. Thank you.
Thank you. Since we have a relatively small group, I'll just have everybody else introduce themselves. So we'll go on to Krista.
Hi, I'm Krista Frederick. I'm the Community Outreach Coordinator for the Telementoring Institute at UT Health San Antonio.
Thank you, Krista.
Thank you.
Curtis.
Sorry, were you saying?
Yes, Kartua. Okay, I'm sorry.
Excuse me. Okay. Yeah, that's no. I was just double checking. Hi, I'm B. Briseda Coutois with Be Well, Texas, UT San Antonio Health. I am the program manager working with the provider network. Thank you.
Thank you. Jen, please unmute yourself.
Sorry, Jen Biddle. I am the addiction recovery social worker and therapist with Community Care in Austin, Travis County, and work among with Dr. Weems as well.
Thank you. Dr. Ramesh.
Hi, I'm Jan Ramesh. I'm one of the hospitalists over at Del Seton. Medical Center and a hub member.
Thank you, Dr. Ramesh. Megan?
Hello, my name is Megan Clark. I'm a PA. I'm working with the UT Heroes group in Houston, Texas.
Thank you. Carmen?
Hi, Carmen Harris with Parmia Care, Substance Abuse Director.
Thank you so much. Rhoda? Rhoda, if you're able to, please unmute yourself and introduce.
She's froze up. She just sent me a text.
All right, no problem. All right, with that, we will move on to our didactics today. Dr. Weems, whenever you're ready.
Great. It looks like the host is disabled participant screen sharing. Could that be enabled?
I just enabled it, Dr. Weems.
Beautiful, thank you.
Welcome.
All right, can folks see my slides? You gonna get a thumbs up? Okay, Megan, gotcha, thank you. Cool, thanks for having me. Thanks everybody for coming. We have a very exciting topic. Who doesn't want to spend lunch talking about documentation? While many people are probably documenting from morning work, but I hope that, as a community, this is a good discussion. I hope it is a discussion about how we can advocate for our patients in the way we choose to write about them in the charts. Again, my name is John Weems. I'm a doc here at Community Care, Travis County's biggest FQHC, and addiction medicine and primary care doc. I don't have any conflicts to disclose. So our learning objectives for this morning are to consider how documentation can further stigma and inequity in the treatment of patients with substance use disorders, to adopt an intentional approach to documenting for our folks with SUDS, and then pretty concretely to reframe 2 common scenarios encountered in documenting care for people who use drugs. Quick proviso. So what this is not, so this isn't a comprehensive guide to interacting with people who use drugs. And frankly, I think the much better person to do it would be somebody who's affected and can speak to what it's like living and trying to access care. And then there's also a really good talk that Claire Zagorski gave as part of the Shout Echo series in last fall. That's a great resource for anybody who's interested. This is also not a comprehensive training on stigma reduction. And for that, I'd kind of point people towards the reset modules available through DelMed. And it's also not a take on local, state, and federal regs on minimum standards, confidentiality, and other key elements of documentation. Instead, what it is I'm imagining is, there's a group of us together today who have the privilege of caring for people with substance use disorders. And I think in doing this work, we probably show our colleagues that this is a legitimate medical condition, and that by showing access to treatment, we can hopefully bring hope that, look, this is a medical condition, can be treated, and also do some role modeling. So that's kind of one of the other goals today, to figure out how we can better role model care for our patients in our documentation. Well, so we'll start with a poll, and if folks could use the chat to respond. Does people think that on the basis of notes alone, you can tell whether a clinician likes a patient? And if people could put in agree or disagree that on the basis of notes alone, you can figure out whether or not a clinician likes it. Oh, good, great. This is great. So split, a good split. Ideally not, but agree. Yeah, that's really good. Ideally not. Right, and actually, if somebody feels comfortable, somebody who wrote ideally not, could you unmute and sort of talk through why is it ideal to not understand whether or not a clinician likes a patient through the notes?
So for me, ideally not, because ideally we would treat these folks with, no stigma attached, without any kind of, any amount of countertransference. Even though we may not like them personally, we're still trying to provide the best care possible. But I still think that without appropriate either medical record keeping education or maybe just passive aggressiveness, some of those things do get through.
Yeah, that's all right. Thanks for contributing. Anybody else, other thoughts? Strong agrees, strong disagrees? I think ideally not, I think is a really great way of framing it. I'm gonna,
I was just thinking time can sometimes influence the tone of the note. You know, if someone's pressed for time and they're stressed or there's other things going on, either in their setting or in their personal life, that can come through in a note that isn't necessarily reflective of how they feel about that patient.
I think that's a great point, right? And time creates cognitive loading that leads to less than ideal circumstances. And I think especially as our systems are building educational models and service lines to better serve these patients, that when you crunch time, you crunch the ability to be thoughtful about notes. Yeah, I think that's good points. So I think starting with a figure that shows up in a lot of educational materials, and I think is an important one for us to have around and accessible. This is from the Reset modules of just showing stigmatizing in preferred language as when we're using our notes. And a couple of things I'll point out. So I think abuse itself, the willful act of misconduct doesn't well describe what our patients are struggling with, and is no longer part of our diagnostic criteria. So those first three categories, I think that's a pretty black and white one we can be rid of. And then as an internist, I'll go down to the clean versus dirty distinction and just point out, and I know Mitch is an ER doc, that a lot of times when we're trying to determine what's going on with a urine study, whether that's urinalysis or urine toxicology, the labels clean or dirty do very little to get us where we want to go diagnostically with our patients. And then they carry this really stigmatizing connotation as well. So I think if we can move from clean or dirty to kind of more precise language about both toxicology results or really any kind of interpretation we're doing, we can also hopefully better serve our patients who use drugs and people with substance use disorders. Then after thinking through stigmatizing language or not, you might ask the question of like, does it matter? So does it matter how we refer to individuals with substance-related conditions? So this is a slide by Dr. Kelly about a study done by Dr. John Kelly up at MGH, asking that exact question about, and the design that they did was like a randomized trial taking folks like graduate level PhD students and clinicians like physicians, and then exposing them to two treatment groups. One was the abuser group and the other was the substance use disorder group. And then there was clinical cases, and the only thing that switched was the words we used. And it turns out that it did matter. So there's significant difference, and compared to those in the SUD condition, those who were substance abusers, when the clinician read that, they're more likely to find that individual culpable, more likely to recommend a more punishing course, and less likely to recommend treatment. And so insofar, this is a study that's often pointed to show that, yeah, in fact, our language matters, and the way we put it in the charts matters. In the wake of George Floyd's murder by the police and kind of another attempt at reckoning and recognition of racism throughout our society's institutions, there's been a number of publications recently asking questions about stigmatizing language in the medical record, and if that is showing up unequally across different marginalized groups, and the answer is yes. So this is a study from Himmelstein and colleagues in 2022 examining stigmatizing language in the EHR. You'll see there, I put table 2 up, some examples. And so they looked not just at SUD, but other chronic illnesses like diabetes, where sometimes some stigmatizing language sounds like patient refuses such and such a diet, they're non-compliant with an insulin regimen. So they looked across conditions, and what they found was that somewhat unsurprisingly, that stigmatizing language was much more likely to show up in non-Hispanic Black patients' notes, which suggests that we could improve health equity if we were better able to sort of have training around this and improve how we do our documentation. This is another study from Health Affairs with similar conclusions, different cohort. They looked at hospitals in Chicago and found that Black individuals had 2.5 times odd ratios of having negative descriptors in their history and physical notes, and that suggesting that there's the potential there to exacerbate racial and ethnic healthcare disparities. And so using stigmatizing language and having that furthered in our notes, we know that that interrupts access to care for our patients, and then it probably takes place in an unequal way and exacerbates health equity issues. This is the final study I'll talk about briefly. So this is a qualitative study that looked at how physicians use stigmatizing language in patient medical records. This is a really busy slide, but I hope for our audience today that it's helpful to have some categories as we're understanding how our colleagues are thinking about patients and working with patients ourselves about categories of negative language and how that shows up. So how the stigma is conveyed. And so I think everybody on this talk will recognize some of these categories. The ones I'll point out are like the bottommost one, right? So unilateral decisions, language that emphasizes physician authority over patients. So she was told to discontinue. I haven't instructed him to. And everybody's probably read a discharge summary recently that says the patient was instructed to stop abusing drugs, something to that effect. And I hope that this can be helpful to people in having conversations with colleagues, or to say, you know, I've read the note, it seems like there's some disapproval that comes through in the way we're discussing this patient, or there's a question of credibility where maybe there doesn't need to be. So I hope this is helpful to have on hand as a way of understanding and having some categories to understand negative language that we use about our patients. And then the next table, table 2, is the other side. So this is how positive language categories come across. And I'll point our attention to the bottom 3. I think the point early, like ideally not, that we wouldn't be able to tell how somebody feels about a patient based on the note itself. I think that brings up a really important point, right? Like if all of our positive characterizations of our patients are the first 3 items in this list, compliments, approvals, and self-disclosure, I think it does raise some important questions to discuss amongst teams about, like, are we seeing things objectively? Is the way we document, you know, just incredible to our colleagues, for instance? I think the bottom 3 here, so minimizing blame, personalizing, and emphasizing bilateral decision-making, are really strategies worth explicitly investigating as a team to try to ask the question, like when we're doing chart reviews and doing our basic QI work, is this coming through? Because I think these strategies can be really helpful. And to sort of compare unilateral versus bilateral decision-making, this is the bottom row in each case. You know, bilateral decision-making makes reference to patient preference in the treatment plan. So examples of that would be, he does not want to add medication, so I will increase the dose. An example in the setting of SUD could be something like, we discussed it during residential treatment today. He has other priorities, which include caring for family members, completing a job he's on, and we agreed to follow this up at our next appointment. Just something like that to really emphasize that there's 2 sides to this and convey our patients in a more positive light. Here's some other suggested provider strategies. So these are directed particularly at providers. So one thing we come across often is sort of drug seeking. And when I see drug seeking in charts, I think that there's a couple of risks here. You know, one is, I think Stefan Curtiz, the scholar of homelessness, chronic pain, and addiction in Alabama, he pointed out once that drug seeking gets you all the stigma of a substance use disorder and none of the medical thinking. And I think he's really pointing out there that so calling a behavior or pattern behavior drug seeking is stigmatizing, but it also risks premature closure. So one strategy that, take it or leave it, is to develop and document a differential diagnosis for challenging behaviors, particularly in our patients who use drugs or have substance use disorders. And on that differential for me is often in the acute hospital setting, undertreated pain, withdrawal, and remembering opioid, GABAergic, nicotine withdrawal, evidence-based, and even stimulant withdrawal is worth addressing in a supportive manner, and all are important to continue engaging our patients. If you think somebody has a substance use disorder, I think it's important to be pretty explicit about that. And if you're not able to fully evaluate somebody, especially in the setting of withdrawal, it's important to be specific about that in the notes too. I put diversion up here, and this is more for us in the outpatient setting, but it's important in the inpatient setting too, right? Loyalties, not exactly, but we are charged to be stewards of the public health and make sure that, especially with dangerous controlled medicines, that those are not diverted. It's a serious duty. And sometimes in our notes, especially when we're using words like drug seeking, concerns around diversion are not made explicit. If you're concerned about diversion, it's worth saying that you are. And if you're not, it's worth saying that you're not. and I think it gets us to a more exact and precise way of understanding challenging behavior to say, look, I'm not worried that this medicine is not going to go in this patient's body, or I am worried about it. And if you are worried about it, there's a whole list of mitigation measures to take and still engage patients. It's not like when somebody's drug seeking or there are diversion concerns, they're not still our patient. The diagnostic tools we have to sort through this differential include a chart review. So it's why it's so important that we have notes that paint our patients in a positive light and are accurate. And then the clinical history using the SUD diagnostic criteria. And then remembering too that the prescription drug monitoring program and toxicology testing are both important tools that have limitations. And I think in toxicology testing in particular, it's very important that we recognize that these, especially immunoassays, they have very limited test characteristics. And we often ask these tests to do things they're just not designed to do. So they can't tell you about a pattern of use. They can't tell you about consequences. There's just so much that tox can't teach us that I think that when we prematurely close, we don't think through tox testing in the same way that we do other kinds of diagnostic tests we do. So that's one set of strategies to address documentation around drug seeking. This slide is to remind us, right, that substance use itself is not necessarily a substance use disorder. And so being able to say, I think we often want to use person's first language and say there's a person with a substance use disorder. So on the one hand, that's really critical. On the other hand, it's important to say too that people use drugs, and that doesn't necessarily imply misfunction, dysfunction, or dysfunction, I should say. And the process of understanding that dysfunction from a motivational interviewing perspective helps set up the treatment plan. But I think prematurely closing on a diagnosis of SUD, even if well-intended, gets us away from some of the work we do as addiction teams. On the one hand, on the other hand, it kind of just mischaracterizes what's often not a problematic pattern of use for patients. So this is the final slide about suggested strategies. So this kind of, again, is provider focused. And when you get to the bottom of the note and you're looking at the assessment and plan, so these are some suggestions, take them or leave them, about how to sort of categorize your thinking. So one is to, when you have a patient with a substance use disorder, separate the withdrawal assessment and plan from the substance use disorder assessment and plan. And I think this does a couple things. One is it helps us really focus on withdrawal and making sure we're assessing the various kinds of withdrawal and having a good thorough plan. And then it also communicates to our colleagues who are reading our notes that the withdrawal itself is not treatment of the underlying addiction. And that's like the water we drink. That's evident often to us who are in this work, but it's really critical learning for folks who didn't have the advantage of that health education somewhere along the way, that treating, supporting somebody through withdrawal is not the same thing as addressing the underlying problem. And then secondly, as we get to substance use disorder assessment and plan, and ideally specifically to each substance somebody's living with or struggling with, it just get used to saying they have or have not been fully evaluated for a substance use disorder, just so we don't get ahead of ourselves and prematurely close. Or even, I think it also is an opportunity for anchoring bias once we get there. And then finally, these are some categories borrowed from a resource I'll share with you next of sort of elements of the plan: overdose prevention, infectious disease prevention and screening, MOUD plan, and recovery supports and/or counseling. And then you'll see under the first three, it's harm reduction, lowercase h, lowercase r, for overdose prevention, infectious disease, and MOUD, which is to point out a couple of things. One is, this is a medical problem. And when we're in general medical settings, helping people with addiction, we need to approach it like every other medical problem. And that involves risk reduction. And so it's to emphasize that we should do the same thing we do for other illnesses, that many of the interventions we have for overdose prevention, setting of OUD especially, are borrowed from the harm reduction movement. And just to acknowledge that that is the hard work of generations of people who use drugs who brought these to the general medical setting. I'm grateful for those. And I hope we can be very explicit to say, this patient is at risk for overdose, and here's what I want to do to reduce those. And then finally, this is just a quick resource for folks. Tucker and colleagues at BMC in 2017 published this checklist of a very thorough, really good checklist for outpatient providers caring for people who use drugs as they discharge from the hospital. And I just wanted to put it as a resource to have on people's radar. This is really helpful if you're on the inpatient side too, to understand sort of relevant data to convey in the discharge summary or things to be thinking about as patients get discharged from the hospital. And a lot of there is a really comprehensive paper, and then a lot of that informed the slide prior. They just did really great work with this. So with that, I'll return to the learning objectives. And I hope they've been achieved for some folks. And I think I'm at time. Good. So any reflections or thoughts? Did anybody change over how they think? Is it still ideal to not be able to figure out what a clinician thinks about a patient based on their documentation?
Thank you, Dr. Weems, for this amazing presentation. I will just open up the floor for any questions from our learning community. Or maybe somebody would like to share some experiences.
Like, has anybody ever talked to a colleague about a note that they found particularly problematic or that kind of misconveyed critical data about a patient?
I was actually going to ask how you would approach that with, a colleague that, offers good care, but maybe documents in a way that, perpetuates stigma.
I'd be if anybody on the group has input, I'd love to hear it. I think a couple of things like the model that we make by the notes we write really does make a difference. And so I think just being thoughtful about how we do our own stuff and building relationships with colleagues who look to us and read those notes, I think that is a long-term strategy for change. I think the other time, if you're looked to as kind of an expert to help with a case, just to kind of saddle up with somebody, better done in person, just say, oh, when I read this, it seemed like there was some mischaracterization of this or that. I think there was some stereotyping here. And that gets to that table 1 from that JAMA article, which I hope can give folks some language around that to have those conversations. I think where I've had most success is to bring it to diagnostic reasoning with other clinicians and just to say like, oh, I don't think we're dealing with a drug use disorder here. It's often a good conversation to get people thinking and to also have that. And then I think talking about risk reduction in particular and framing that in medical sort of our medical lexicon can be really helpful. Does that answer your question? I don't think there's like a one size fits all of like how you saddle up somebody and kind of have a conversation about that, but those are some of the tactics I've used.
Yes, thank you. Appreciate it.
Yeah, and John, if I can add 2 examples, when we were starting the B team early on and Rich Botner was making a big sort of campaign around this, I think it was effective to say, this is an effort we're all trying to do. So it wasn't about like the one person, it was like, we're all working on this. And I even remember, I feel like I'll always remember a colleague of ours, seasoned hospitalist who was signing on in the morning. And I think it just so happened both Rich and I were there. And he was, giving us this patient and he said, oh, heroin abuser. And then pretty much with an eye roll was like, oh, I'm sorry, guys. I mean, person with substance use disorder. And we just said, hey, thank you. And I actually think that like, that was the first step of just changing that culture. And then lastly, not all of us work with trainees, but I found it to be really effective with trainees to once again, just say, this is something I pay attention to and that we're working on together. And similarly, celebrating like I also remember when a resident in the emergency department said, this woman is a 52-year-old with alcohol use disorder. And I stopped right there. I said, thank you. And I feel like that gets the attention of the medical students, the interns, like everybody sort of hears that. And it's hard to pay attention to those examples to say thank you rather than to point out the bad examples. But I think they're just as, if not more powerful.
Thank you so much. We'll now move on to announcements. Echo IT, if you could please share. Thank you so much. So Be Well Texas is a welcoming environment with caring professionals who are ready to help people start or continue their journey towards recovery. Be Well Texas is committed to expanding equitable access to compassionate evidence-based treatment and care for substance use disorder throughout Texas. Next slide, please. Our next Shout Texas Echo is on Thursday, March 17th. So please do join us. We have some exciting speakers. Next slide. The Texas Substance Use Symposium is on March 24th and 25th. They have both in-person and online options. So check out their website and do register. Next slide, please. And last slide. Thank you. The Beeville, Texas Clinic offers high-quality treatment for addiction recovery at low, no pay, or self-pay insurance, so all patients are accepted regardless of their payment ability. Thank you. We will now move on to the case presentation. Dr. Katona, once Echo IT shares the case, you may take it away. Thanks.
Thanks, Shreya. And while the case is getting put up, just thanks again, Dr. Weems, for your presentation. As a trainee, I know my documentation is far from perfect. So I know I'm sure there's times where I'm not using person first language or whatever it is. So I enjoyed that. And thanks for that, those reminders and those strategies. So, and yeah, I'm really excited to get to join everyone for the Shout Echo. It's my first time being on one of these. I've gotten to watch some of the prior ones on YouTube, but thanks to Alana for inviting me to do this case. And I'm really excited to learn from all y'all and hear your thoughts on this. I don't think I've ever given a presentation where I'm really going to be the one doing more of the learning. So I guess with that, I can kind of jump into the actual case itself. So I thought this was kind of an interesting one. It was a pretty common chief complaint for the ED. Even a pretty common presentation. This was a 61-year-old male who presented as a code STEMI after syncope, and he was coming in with altered mental status. I guess I can kind of set the tone with going over the questions that I'm hoping to get some answers from y'all on. This case was with a patient who was on Suboxone, and so that's kind of where some of my questions stem from. And I'll go into more detail about why. But the first one is, given the ceiling effect of buprenorphine and the inclusion of naloxone and Suboxone to prevent misuse and overdose, it's a very safe medication, and adverse effects are more rare. But are there scenarios in which that might be a consideration, that might even be a cause of this kind of presentation of syncope or altered mental status? Or is that something that's profoundly rare, and our diagnostic considerations should go elsewhere? And then to what degree would other medications, other interactions, because there was kind of some concern there with this patient, other sedating medications like benzodiazepines or illicit drugs, could that potentiate adverse effects with Suboxone? And then lastly, just kind of in general, in this kind of presentation or chief complaint of altered mental status or in the post-syncopal patient, of a patient who is on MAT, what would you recommend an emergency physician consider versus maybe all comers with that presentation? All right, so the actual encode for this patient was that EMS was en route from home with a 61-year-old male whose wife had called EMS after he had quote unquote passed out. And she was a little bit worried about his breathing. And EMS said that on their 12-lead EKG, he had a concerning EKG for STEMI. And so, the emergency department and interventional cardiology, the cath lab, everything at Seton Medical Center was activated for the code STEMI. EMS gave aspirin. They started giving fluids by IV. They put the patient on oxygen. And when the patient arrived, he was indeed confused, drowsy, disoriented. He was awake and talking to us, but clearly altered. His vitals were notable for hypotension. He was kind of 80s over 60s initially. And right off the bat, kind of got our immediate studies, a point of care glucose, EKG, and we did a POCUS echo. by and large, those were unrevealing. He was a little hyperglycemic, and his EKG did have the right bundle block, but the STEMI was pretty quickly, a code STEMI was pretty quickly canceled, and ACS was kind of put a little bit towards the back burner as a etiology of his presentation. So a lot of the history came from the patient's wife, again, with his mental status. She said that, kind of throughout most of the morning, this was early afternoon, the patient arrived, and throughout most of the morning, he had appeared, quote unquote, drunk to her. And then, but prior to him kind of just sort of collapsing, and then he had to be helped into a chair when she called EMS. His past medical history was notable for a traumatic injury as a young adult to his left lower extremity, for which he, and I don't have all the details to this, but for which he had ultimately progressed to having sort of a dependency on opioids for his pain control, and then at some point had been diagnosed with opioid use disorder and was being treated with Suboxone by Dr. Lee. And his dose, I'll kind of note, again, I very limited experience with giving or prescribing Suboxone. So, but his dose, I'll just note, was 2.5, 2 and 0.5 BID. So I imagine a pretty low dose there. And then also notable that his wife kind of administered and was sort of in charge of his Suboxone. And she noted that he was missing 3 films after she called EMS. She noted that. So to kind of jump through his ED workup a little bit, was essentially largely negative. There were a few abnormalities that we kind of thought could be contributors. He was a little bit hypercapnic with a PCO2 of 53. He had a mild AKI. His orthostatic vital signs were normal. His troponin was negative. So by and large, most of the etiologies that we would typically consider for his presentation were kind of ruled out. And he was admitted actually to the ICU initially, just given his mental status and hypotension, and was overnight was in the ICU and kind of quickly improved. His mental status and blood pressure improved throughout that first hospital day. Opioids were held initially, and then he was transferred to the floor by hospital day 2. His AKI resolved, and going through the hospitalist notes, the hospitalist had a discussion with the patient's wife about restarting his Suboxone and kind of his experience with Suboxone. And there was this interesting statement in the chart that the hospitalist said, quote unquote, that it sedates him when he takes it. That is what she told the hospitalist, evidently. Which was, it's kind of unusual, I would think, at that. But in any case, the hospitalist restarted his Suboxone on a QAM dose. He was monitored on that for a couple of days and did very well, and then was discharged home on hospital day 5. So to kind of go through the rest of this sort of and I'm sorry, I guess I'm kind of going a little out of order on our sheet here, but I thought that. Again, this was kind of an interesting case just because I'm curious to what extent the group here thinks that the Suboxone could have played, if at all. If this is a patient who was on this 2 and 0.5 dosing BID, and the wife was suggesting that perhaps that was, I guess, maybe a larger dose for him, and then he took a 4x dose this day on a day where he was already perhaps volume depleted and hypotensive. Could that have maybe caused his presentation? So that's about it for the case summary. We can kind of move on to some of his substance use history here. There weren't any other other known like co-intoxicants that he was using. There was a hospitalization that I saw on his chart from several years prior where he admitted to like surreptitiously maybe using Xanax, like PRN, that like wasn't prescribed to him. So, there wasn't any specific suggestion that was what was going on this time, but that was one thought, was with his wife stating that he was quote unquote drunk. Did he perhaps take something else that was also causing some sedation or also putting him at risk for syncope? So Yeah, I think I'm pretty much ready to kind of turn it over to the group to maybe go over our questions here. And I can also answer any further questions about the case as well, if I kind of left something out.
Thank you so much. That's a great case. I guess my first question to the group before we sort of dig into it is, does anyone have any particular questions for the case, any information that you want to know more about? Yeah, go ahead.
I have a question. Did he ever get like a nephrology consult? Because it sounds like he had an AKI and he's got a lot of chronic diseases going on, and he came in hypotensive. So did they find anything more?
We did not get a nephrology consult either in the ED or during his hospital course either. He did have an AKI. I think it was relatively mild. His presenting creatinine was about 1.8, 1.9, if I recall. And I think it was judged to be pre-renal. And it did resolve overnight. I think it's a great thought. And but the answer is no. We didn't end up having a nephrology consult.
And it wasn't mentioned. I had questions about, I assume that you did the head CT. You didn't seem any obvious trauma, because I see a Pixaban in a 60-something-year-old who may have a history of substance use disorder. Did they fall and knock their head? What happened? I don't know. But I presume you guys did all that. It just kind of overlooked in the case report.
Yeah, sorry. I kind of glossed over, I guess, some of the tests that we did. But yeah, he did get a CT. There was really not much in the way of history exam for trauma, but yeah, with him being on thinners, he did have that. He had a few other tests. I mean, we ruled out, he got a dimer, PE was ruled out with that. So I think, ACS, acute CHF, PE, CVA, hepatic or uremic encephalopathy, all of those things were kind of excluded with our workup. You're right. I kind of neglected to mention some of the tests that we did, but right, those were all kind of excluded in the ED workup.
Right on. No, it's great. I figured, I mean, you guys do a great job in the ED. So, so in a guy who's 61 and who uses those medicines at home on the home medicine list, little hypotension, and he's altered, something maybe with his heart when he was coming in with a touch of AKI. What do people think about, workup was pretty much negative other than the AKI, which resolved pretty quickly. Maybe he was just a little dehydrated. What do people think about the ceiling effect of Suboxone? Like, can it itself cause altered mental status or oversedation? Is it possible? Does anybody have thoughts about that? That's maybe not a hub expert. Has anybody seen it cause oversedation?
I've had a few patients where I'll ask them like what time they're taking their doses, and if they take them late at night. I feel like more people have a problem getting to sleep, that it keeps them up. So I haven't really seen any sedating. And this guy was on 2 milligrams BID, so 4 total. That's such a small dose. I would be really surprised if that was sedating him. I would wonder more if there was any talks done to look for any benzos or any other downers.
Yeah, I think that's a good thought. I think on average it is pretty low dosing wise, but I think theoretically possible. And I mean, the wife even said that it sedates him. We do know, I don't know if anyone has thoughts about the ceiling effect. I mean, it's the safest opioid we have in monotherapy for overdose, but it's still an opioid. And he's 61 and everybody's different with their liver metabolism. And so I think it's possible that's part of it. I mean, theoretically, he took a 4x dose, right? If he was missing some of his strips maybe. But I thought it was interesting, the list of inhalants and other things that were in his substance use history that might not show up on a tox screen. I'm also curious to hear, do people always see benzos show up on their drug screens? We don't always hear when we really believe they were taking them. So I think that's always something to wonder about. What thoughts do y'all have about other substances he was taking prior. I can't remember seeing Suboxone, gabapentin, apixaban. I can't remember what else. I think an antihypertensive, but I can't remember. Could any of those have synergized to contribute? What if he took extra of other stuff? Did wife count the other things? Does anybody have any thoughts about that?
Yeah, like his hypertension meds, if he took too many of that, that'll bring his blood pressure down and he'll drop. Or if the doctor recently changed it.
The other thing is this guy has renal dysfunction. So for the crew, right? Buprenorphine is removed by biliary clearance. So I'm not worried about failure to clear buprenorphine. Just like Dr. Walker said, we're worried more about more went in and not enough getting out. Not the same story for gabapentin. So gabapentin, I'm a little concerned, right? That's on the list. It can present with people can look drunk when they're on it. The other question I had is about his alcohol use disorder and remission. It's worth just investigating a little bit, figuring out where we're at with that. That drinking can make you look drunk sometimes. And then it's a pretty good diuretic too. So here's a person on other diuretics who had a pre-renal AKI. So it could be he was taking more of his diuretics or an old diuretic that's come back from with alcohol. The other, I think the benzo is a good thing to look at. Alprazolam's, a lot of the benzo immunoassays have very poor test characteristics for low dose of alprazolam. So if you really want to know, you need to do an LCMS or GCMS. And then Mitch, could I ask, man, there was the alprazolam, you did great chart check, looked through the history. He had described non-prescribed use in the past. And then I noticed it showed up on his hospital meds. Mm-hmm. Was that carried over from a final, a prior note? Was that like a PRN in case he went into withdrawal, or any more? And it might just be something that showed up in the chart and we don't know the rest, but I'm wondering if there's more to the story there.
Yeah, so that was one of his PRN inpatient meds. And I kind of just pulled his med list off and was trying to piece together as much as I could from the inpatient team. And yeah, my assumption was it was maybe a PRN for withdrawal, but I'm not sure what the context of whether it was like even like anxiety, if that, I wouldn't think so, but I wouldn't think that would be the PRN use for it. But yeah, that wasn't like a scheduled certainly med, but it was one of his PRN inpatient meds that was listed.
Yeah, I thought it was interesting that the hospital med list was longer than the home med list and that there were more drug interactions. Do you guys have any opinions about, so we sort of talked about Mitch's first question, but like to what degree can other medicines potentiate Suboxone's adverse effects? In this case, especially like altered mental status, oversedation. Like, is it possible? Do people worry about that?
I think it's possible. We definitely worry about that when we have an alcohol withdrawal and also opiate withdrawal, and it becomes very complicated, but we also don't want to potentially oversedate the patient. We're trying to treat the most fatal of the two scenarios.
Yeah, and with outside the hospital, outside of withdrawal, there is always a concern that oversedating medications can synergize with each other and make things worse. So you can see a benzo and Suboxone cause problems. Even gabapentin, Suboxone, just depends on the person, and it depends on a lot of different factors. So it is something to note. I think the ceiling effect, when you hear about that, they're really talking about monotherapy. And correct me if I'm wrong, Dr. Weems, if you have any other opinions about that. So it sounds like, Mitch, yes, you can really oversedate someone with multiple different medications. So it's still something to watch for with Suboxone. And if somebody is on Suboxone as an ER doc, like they're on an opioid, so what else could be contributing? Just to bring it up as a teaching point, like I mentioned sort of polypharmacy on that hospital med list. Does anybody have thoughts about that with just a mind to Suboxone in general, since that's sort of our focus? Anybody see things that jumped out at them on that list? They're PRNs. I'm guessing he did not get much of that. If he was altered, he was probably slept it off all night and then didn't get any of that. But I saw, just for me, I think I saw PRN trazodone, tramadol, the Suboxone, can't remember what else. And I just thought it was sort of an interesting mix of choices for somebody who presented altered. I've had cases of serotonin syndrome, even monotherapy with Suboxone, who've had liver dysfunction. This wasn't necessarily this guy, but tramadol and trazodone are also highly serotonergic. I'm a CL psychiatrist, so I can't help myself. Like, that's what I do for a living. But it's notable to remember that all opioids are serotonergic, and Suboxone in particular, buprenorphine is too. So I thought it was notable. Like, his list was much longer when he's there potentially for, medication adverse effects. What thoughts do people have about, things that ER physicians could potentially or should potentially be thinking about or paying attention to when they're helping folks with substance use disorders? What to be aware of, what to not forget about?
Well, I don't think this is really what you're asking. I'm just drawing a connection to Dr. Weems' talk earlier today. I'm just struck by, there's a number of potential factors here, but it seems easy for people to focus in on the Suboxone and blame that med. And the ripple effects are that I think it causes then any physician or others who came in contact with this case or heard about this case to then be like, oh, I'm more nervous about prescribing that med, or I've seen bad things happen, when like there's lots of other. So I'm just struck by the potential risks of making a diagnosis when we're unclear, and how much that could play in, just like the Suboxone jumps out at us. Whereas me as a hospitalist, the gabapentin I see so much gabapentin toxicity in people who come in with AKI. I see them with asterixis, and anyhow, that was one of the things I was thinking about when I hear this case.
I guess maybe the point for me then, from what you just said, Dr. Moriatis, is that that's really going to be like a diagnosis of exclusion then. I mean, so it's going to be STEMI until proven otherwise, and then it's going to be intracranial hemorrhage until proven otherwise, and we're going to go down the list. We're not going to be sitting here saying it's Suboxone or any other like medication, sedation, etiology until we've really run through all the big ones and not anchor, I guess, maybe on that. So thank you. That's a great point.
Yeah, definitely. And I think I'm also trying to say, like, it's the Suboxone potentially in context of all these other meds. Like, I also just worry about villainizing the one medication when there's so many other potential contributors here, and the message that can send as we try to increase comfort with Suboxone, which has a lot of benefits in certain populations.
That's really helpful.
So, and I'll bring, Megan made this great point in the chat. Another thing to think about is he taking this buprenorphine and rule out OD in case if he's returned to use. I think that's a really good point. I think the other thing that happens with our patients on buprenorphine chronically, it's a weird medicine to take, right? The whole process of letting it sit under your tongue, medication administration errors are very, very common. And that can lead to lower serum levels. So the buprenorphine itself is more likely to have a sedating effect if you've been taking it while you smoke cigarettes for a couple of weeks and you're having, and then less is getting in, or you're taking it while you drink your coffee, less is getting in. And then all of a sudden you're just taking your prescribed dose. And you can have some sedation related to that. So I think thinking about stepping back and, like Chris's point, let's not anchor on SUD. Let's think about, well, there's a chronic relapse. So how can we gather some information to figure out how this guy is doing, and if there is more going on. And then I would just add that to the differentials. Like, is this a administration error that is chronically that's now leading to a higher serum level, which happens a whole lot. Does that make sense to folks about it's a sublingual administration, blah, blah, blah? Anybody have any questions about that?
Yeah, we've also seen, say someone takes a different version of buprenorphine, and then we only have the films here. The films, it's also good to know, are more potent. So we've had people where you think you're giving them sort of an roughly equivalent dosing, and they're a lot more sedated on the Suboxone film that's so close to dose than their, Subutex or whatever. So it's more bioavailable apparently. So that's something to note. So just to kind of review what we talked about, Suboxone is the safest opioid we have, right? As far as risk for overdose, it works. We didn't talk about it, but we all know that it works really well for opioid use disorder and can be really helpful for pain. He was on a pretty low dose of it. Maybe it could cause some oversedation and altered mental status if he tripled his dose and wasn't, taking it properly beforehand in particular. But to not necessarily anchor on just that and be mindful of the fact that Suboxone still is sort of stigmatized and jumps out. And since it's something that not everybody is as familiar with, it ends up being the one that you can sort of anchor on because you're not as aware of, how it works and what the likelihood is. I think flipping it in your mind of if it just said oxycodone 5 twice a day, like, would you be as worried about it? I don't know. And then we talked about sort of other drugs can potentiate and synergize and lead to overdoses, and not to forget how other drugs work, given gabapentin, AKI, that sort of thing. Don't underestimate other sedating medications potentially, even though they seem more benign. And then it sounds like sort of takeaway from ER physician, like your last question. I think it always, substance use is a part of the person, right? But not the whole, and take it into account, but continue to think of all the different kind of ways that somebody could be presenting in this manner. Does anybody have any other thoughts, any other questions? Mitch, do you have any thoughts or questions about this case? And do we know what happened to him?
He did very well throughout his hospital course, and was discharged back to home with his wife, who kind of resumed helping him with his medications. And I haven't followed up with him since then, but yeah, his hospital course went very well. But no, I mean, I don't think I have many other thoughts other than to say thank you guys so much for going over this with me and sharing your insight. I really appreciate it. It's a great opportunity for me. Really thankful.
It's a good case. Thank you.
Thank you so much, Dr. Walker. And this was a great case, a great discussion. Thank you all for joining today's ECHO session. As a reminder, to earn CME and CNE credits, please complete a post-session survey using the link in the chat. We look forward to seeing you at our next session, which is on March 17th, which is Thursday at 12 noon. Have a great rest of your day. Thank you.